Hello everyone, I am Dr. Divakar, a senior lecturer from the Department of Prosthodontics in SRM Dental College. In this presentation, I am going to discuss the most important treatment procedure till now we are doing in our clinic as well as in UG graduation, that is the complete denture. But even though implant dentistry have advanced tremendously and many patients today prefer a fixed dental processes, the conventional and complete dentures still play a vital role in the modern prosthodontic practice. They remain the treatment of choice in situations where patients is having the economic constraint, medical compromise, and unfavorable anatomical condition. However, not all the edentulous patients can be successfully managed with the conventional complete dental, which we used to do in for a 5 visit appointment. Certain compromise cases will be required a special additional care, modified techniques, as well as the treatment protocols, which is specialized for these patients. Those complete denture are called as special complete denture, which is for a special people. To introduce special complication, why we need it? Because when our conventional complication does not suit the need of the patients, a patient is coming for a complication rehabilitation, they require two needs. One is function, another one is aesthetics. And the complete denture has to be completely retentive, suitable for stability, and it should not have adequate support to get success and long-term uses for these patients. So to have that, we need to select which type of special complete denture we have to give if a patient is compromised. Various types of a complete denture, conventional, unconventional complete dentures are there. First one is the characterized complete denture, which is characterization of your teeth or your gums according to the patients. Second is exceptional complete denture when patient mouth opening is very less or microstomia patients. So they will be like we can't place the complete denture directly inside and remove it out. So in such cases, we can go for a sectional complete denture. Q-shield denture, it is a type of RPD when patient's remaining natural teeth of 2 to 3 teeth will be present in the patient mouth and the patient is it's completely periodically compromised and patient is not willing for extraction. In such cases, we can go for a Q-shield denture, the denture which will cover the teeth all around and we will give the denture. When we see this picture, you can appreciate that. Then a flexible denture, which we are routinely used for most of the RPD cases nowadays and remainings will be the cheek plumbers, hollow denture, immediate denture, labeled denture, liquid supported denture, metal based denture, denture fabricated by neutral zone technique, over denture, salivary reservoir denture, and plantar denture, which we will discuss case by case in this presentation. So, what are the indications for these special complete denture? First one is the most important, that is the atrophic ridges, because immediately after the extraction, the ridge resorption is the physiological process which will happen immediately after the extraction. All cases is, and if patient is having this extraction sites for longer time, and definitely there will be the severe resorption, which will compromise the conventional complete denture fabrication. Second is, as I told, microstomia, when we can't place a complete denture inside patient, we can give it as sectional. Then flabby tissue, when there is bone loss is there and tissue overgrowth is there because of long-term use of the complete denture, then there is chances for flabby tissues which will displace the new complete denture, which will fabricate in the conventional manner. So we have to fabricate it in the undisplaced form. How we will fabricate is that dentures or special complete denture. And then last one is the labially inclined premaxillary cases. In some cases, when after extraction, if the ridge contour is not done with the help of alluloplasty, or a patient is having the premaxilla slightly protruded. In such cases, if we give a conventional comprehensive which will it leads to a class 2 profile for such patients. To avoid this, we can go for flangeless dentures, which we will discuss in the cases. And other indications like bruxism, bony excesses like tori, xerostomia patients, and systemic conditions like hypertension or diabetes. So first case, so 85 years female patients reported to our department. When we view the extraoral lateral view of the patient, we can able to appreciate a prognostic profile. So this is class 3 of these patients. Then when we examine the intraorally, the completely edentulous maxillary and mandibular arch can be able to find. But the maxillary anterior region has slight flabby tissue and the mandibular ridge is completely resolved in these cases. So to rehabilitate these patients, we just utilize a technique called window impression technique for flabby tissues and neutral zone recording for the resolved ridges. And why we are doing it, we will discuss step by step. So first we did the primary impression, then made a custom phase slightly modified with window in the flabby tissue region. And then we evaluated the custom tray inside the patient mouth. Then we did the conventional border molding and impression with the help of ZOE. The zinc oxide original paste has been done in the conventional manner in the remaining areas, except in the flabby tissue areas. In the flabby tissue, we applied the material which is low viscosity, especially light body impression materials or impression plaster also can be used, and then reseated in the position. And we didn't did any movement so that the flabby tissue will be recorded in the undisplaced manner. After this is the final impression. So the remaining areas will have been recorded with the help of ZOE paste, and the area which is flabby has been recorded with the help of light body in the undisplaced manner. For reserve bridges, we didn't did the conventional border molding. We did the all grain technique so that we can record as much as tissues as possible, as much as area as possible to get the more support from the ridge area which is available inside the patient board. And then final impression is made with the help of light body elastomeric impression. Then master cards have been poured with the help of dental stone. So next, after that, we need to do jaw relation. But here, since the patient is completely resolved, and especially mandibular complete denture is resolved, when we give the denture in and we arrange the teeth in the manner of U shape or V shaped, then we arbitrarily, then it will be leads to a displacement and instability of your complete denture. In order to avoid that, we need to place the teeth in a space where the tongue musculature as well as the cheek or buccal musculatures will be having the neutral forces acting on it. Such area or such zone is called as neutral zone. It is a potential space between your lip and cheek on one side and the tongue on the other side. So the action of these muscles, cheek muscles or tongue muscles, will be neutralized in these areas. When we arrange teeth in these areas, then the denture will be stabilized in the patient mode, even when patient is doing all movements of the functional movements of the mouth. So how we will record this neutral zone? First, we made a denture base on the mandibular arch. Then we made a spikes with the help of stainless steel wires. Above that wire, we place various material can be placed to record your neutral zone. Example, your impression compound, glistening compound, putty impression material, tissue conditioner. But we use the admixed method, admixed material, which is a mixture of your impression compound and glistening compound. We place this material on the lower arch and ask the patient to do all the functional movements like lip sucking, swallowing, opening mouth wide, and closing the mouth, speaking. All the movements has been functional movements has been done. After recording the neutral zone, we made a putty index around the neutral zone and we replaced the material with the help of wax so that we can go for the next procedure is the teeth arrangement. But teeth arrangement here first, we have to do the lower teeth arrangement because we record the neutral zone in the lower arch. Then the upper teeth arrangement has been followed. This is the final teeth arrangement and try-in. Here, teeth arrangement we done like anterior edge to edge and posterior crossfit because patient is having slightly aprognathic profile and is the final denture insertion. This is the pre and post rehabilitative view of the patient. Coming to the case two, a patient reported when we examined extraorally, we can able to appreciate a sunken cheek for this patient. And the patient is completely edentulous, upper arch is well rounded, but lower arch is again a resolved ridges is noted here. So come for management of this sunken cheek, we plan for a cheek plumbers, but we can give cheek plumber as an undetachable and a detachable one. So if we go for a detachable one, then it will be more advantage because when patient require, they will use it. When it is undetachable, it will increase the weight of the process, which will compromise the retention of the processes. So going for the steps, first we did the conventional steps like primary impression, secondary impression for maxilla, conventional manner. But for mandible, because resolve, we went for all green and then masterclass and correlation try-in has been done. After trying, we place a block of wax at the buccal surface of your flange area near premolar to molar, and we just elevated the cheeks to reduce the shrunken cheeks. After this, the cheek plumber has been removed from the denture. Denture has been cured separately. Then we just again placed inside the denture and the cheek plumber. Then we evaluated the cheek plumbers. First, unilaterally, we placed the cheek plumber. On the right side, we placed, but left side, it is not placed. That's why the shrunken cheek is still present. And there is a drastic change when we place both the cheek plumber inside the patient mouth. So the aesthetics have completely changed with the patients when we see in the third picture. So for attaching these two separately cured complete denture and the cheek plumber, we did a customized attachments. So for that, we used a female component as a lingual button, which will be used in the orthodontic purposes, and the orthodontic wires, which we bend as a male component. This is and the female component is embedded in the complete denture with the help of self-cure acrylic resin, and the male component is embedded in the cheek plumber with the help of self-cure acrylic resin. This is the final denture and final indenture which is inserted in situ. This is the pre and post rehabilitative view of the patients where shrunken cheek is completely gone. Coming to case three, a patient of completely edentulous is reported with well-rounded mandibular arch, but maxillary arch is slightly resolved with a flabby tissue in the anterior region. When we did the jaw relation for this patient, we were able to find the maxillary occlusal rim height is slightly more. The interridge uh, distance is a little bit more, which will increases the weight of the processes of maxillary arch and compromise the ridges because ridge is already resolved. So for these cases, we planned for a hollow complete denture, which will have a hollow inside a hollow cavity inside your complete denture, which will reduces the weight of the processes. And for the flabby tissues, we planned similarly the window impression technique. So the procedure starts from primary, secondary, as I explained before, the flabby, how we will record with the help of window technique, then master cast, and then jaw relation. We can able to find the height, vertical height is of maxillary occlusal is more, which will increases the weight of the processes. So we did the try-in. After try-in, we just duplicated the try-in upper complete denture and poured it with the help of dental stone. And over it, we made a, thermoplastic sheet splint, and after that, we placed the splint on the master cast. We evaluated the available space of height as well as the width with the help of endodontic files. Then, according to that measurement, we made a putty index in the shape of U-shaped arch shape. A putty index has been fabricated. Same similar width and height. We just carved the same width with the help of the soap also. So during packing, what we did first, we placed the uh, packed material inside that is the heat cure acrylics inside the flask. After that, we placed the putty index and then we did the trial closure. Then after the trial closure, we removed the flask again and replaced this putty index with the help of the soap, which we carved similar to the dimension of your putty index. Then we packed completely and cured in the conventional manner. After curing, immediately we checked the weight of the process, which is around 30 gram. And then what we did three holes in two in the anterior and one in the posterior, two in the posterior and one in the anterior region. We removed this soap with the help of three-way syringe, water, and orthodontic wires, and blocked the hole with the help of self-care acrylic resin. After removing the soap, when we evaluated the weight has been decreased to 6 gram, which is around 24 grams now. And this will be the pre and post rehabilitative view of the patient with good retention and stability. So when come to case four, the patient previously denture, we had a patient reported with denture is frequently getting fractured. And when we evaluated intraorally, patient is having slightly overgrowth of maxillary tuberosity and supramandibular anterior teeth, which is slightly going into a syndrome called a combination syndrome. So to stop this combination syndrome as well as to reduces the fracture of your maxillary complete denture, we just fabricated a metal reinforced maxillary complete denture opposing the mandibular cast partial denture. So the step starts in the conventional manner, like primary impression, primary cast, final impression, master cast. Over the master cast, we did the batch pattern for your metal framework in the maxillary arch and the mandibular arch, and screw were attached. Then conventional casting has been done. This is the final metal framework adapted over the cast. The metal framework was tried in inside the patient mouth, then jaw relation done, then try-in teeth arrangement and try-in has been done. This is the final rehabilitated view, intraoral view of the patients. This is the pre and post rehabilitative view of the patients. So to reduce the combination syndrome, this metal reinforced denture will won't displace the tissues, will won't compress the tissues, so combination syndrome will be decreased. So next patients with the 658-year-old with only three remaining teeth in the upper arch, and that also very much predominantly compromised and greatly mobile it is. And when we evaluated intraorally, we can able to find that there is a dryness all over the maxillary arch, and we did the mirror stick test, which evaluated that xerostomia is positive for the patient. So to decrease the xerostomia and dry mouth of these patients, we did immediate complete denture along with salivary reservoir, into which we can place the artificial saliva, which can be useful for patient in the routine uses. So the step starts at primary impression made, secondary impression made, then jaw relation done, and try-in has been done. And immediately after try-in, the final cast, which we poured from the secondary impression, has been modified. We removed the teeth, which we are going to extract during the insertion time because we are fabricating the immediate complete denture, right? So we modified the cast and we removed the anterior teeth, which is present remaining, and we did the complete teeth arrangement in this semi-adjustable articulator. After the teeth arrangement, we made a wax up for a salivary reservoir in the palate region. Then we just again duplicated the wax up cast. Then we poured it with dental stone. Over that through, we made a lid, reservoir lid with the help of wax. Then we did the conventional curing for the wax up denture and the through reservoir through. For lid, we did curing with the help of silicone, which will helpful to press it as well as to release the salivary substitute inside the lid. So this is the final denture with the lid, and we just examined whether the liquid is coming out or not with the help of betadine. So when we press that lid with the help of any instrument like shank of the instruments, and so the betadine is coming out, we can able to appreciate in this picture. So this is the then during insertion time we extracted the teeth, remaining teeth which is mobile, and then we immediately we place the denture inside the patient mouth, and then we evaluated the patient mouth immediately after a day and after 3 days. We also instructed the patient mouth not to remove the denture for a whole day because if they remove, they can't place it back. And we removed it after 3 days, and after 3 months, we did relaying also because of ridge remodeler. Coming to case 5, we just seen a case which is partially edentulous maxillary arch and completely edentulous and also resolved mandibular arch. The remaining teeth in the maxillary arch is predominantly sound, so we just plan for O-ring attached over denture and coping attached over denture for the upper arch and conventional complete denture for mandibular arch. So we did the RCT for this patient for the remaining natural teeth. Then tooth preparation for O-ring and metal coping has been done. Then O-ring post preparation done, and O-ring was cemented with the help of GAC, and metal coping has been fabricated with the help of casting. And then we did the cementation of that with the help of same GAC cements. Then the conventional techniques has been followed like primary impression, secondary impression, jaw lesion. But after jaw lesion, we can able to find patient is having slightly protruded premaxilla with the deep anterior undercuts, which will leads to prosthesis that will have a flange outside this undercut can cause irritation to the patient, discomfort to the patient, and proclaim the upper arch, which will be aesthetically compromised. So when he did the jaw lesion and mounted in these images of like here also we can able to appreciate that maxilla is slightly protruded compared to the mandible. So to reduce this, we planned a slightly modification in our denture. So how we did the jaw lesion because slightly class 2, we removed one premolar in the lower arch and we did the teeth arrangement. Then curing has been done in the conventional manner. To avoid the thickness in the anterior undercuts area, we removed the flange and made the denture into flangeless denture. And the patient, when doing the procedure, also patient is having severe gag reflex. So to reduce the gagging, we remove the palate as well because the denture is over denture and it will get supported from the attachments also. So we remove the palace and made the denture into palaceless denture. So for make the overdenture attachments, we place the female component on the top of the O-ring intraorally, and we picked up in the final denture with the help of silky acrylic resin. This is the final rehabilitative view when we can see there is no anterior flange and palate has been removed. This is the pre and post rehabilitative view of the patient. Similarly, if patient is having remaining natural teeth, but it is not predominantly good, then we can go for attachments like bar attachments also. When compared to O-ring, we can go for bar attachment and remaining attachments is also there like magnet attachments. These are all depends on the inter-arch space, how much you are having. So if bar attachment we are going, we have to have an inter-arch space of 11 to 20, 15 mm. If we go for O-ring attachment, we need at least a 10 mm of inter-arch space. And if we go for magnet return, we can go even if we have a less than 8 mm of interarch spaces. Then teeth is also important in forensic odontology because in major accidents or any accidents or any major issues happens around the teeth is the major identification marks in many of the patients to identify the identification of these patients. So if a patient is removed all the teeth, then it is very difficult for them to identify the identity of the patients. In such cases, if patient is wearing any denture, it cannot be a complete denture or any denture, but if we give some marking inside the denture, it will be easy to evaluate and easy to find patients complete denture. With the help of the complete denture, we can find the identity of the patients also. So in such cases, so we can either do some labeling inside your denture with the help of QR code, or we can put the phone number or a name of the patient, photograph of the patients, whatever possible. So if we scan that QR code, the details of the patients can be visible in your phone. So it will be helpful to identify the denture patients. And in most of the patients in the rehabilitated complete denture are old age people. So there is more chance like they can lose the complete dentures somewhere. In such cases, and all this labeling will be useful. And one more technique here, we just tried the NFC tags because most of the phones, mobile phones, Android phones, which are available now, is having this NFC tag scanning. So if we get the phone near to this denture, it will scan automatically and will provide the details of the patients. Now, complete denture is we are using a lot, but because of this, many the dentistry is completely evolved as a digital technology now, like 3D printing, CAD CAM. So this patient, he's been coming to us from 5 years old because the patient is having a non-syndromic oligodontia where only remaining teeth inside the patient nose is four, two central and the two molars, and lower arch is completely resorbed as well as complete flabby tissue is there, and all the teeth is constantly missing. So this first picture, second picture shows the previous denture of the patient, which is an overlay denture. When we evaluated denture, the denture is already broken and it is completely attrited. So we just plan for we use the digital technology and we plan for 3D printed overlay denture for this patient. So we did the primary impression, secondary impression, and master cast. The master cast has been scanned with the help of the extraoral scanner or laboratory scanner. Then we did the jaw relation. Jaw relation also scanned. Both the cast and the jaw relation has been aligned with the help of CAD software. Then teeth arrangement is done in the CAD software. After that, a trial clear acrylic 3D printed, a tri-indenture has been fabricated, and then it is tried inside the patient both for vertical dimension and occlusion and the smile of the patient. When it is confirmed, then the denture base and the teeth has been separately 3D printed. Then both the denture base and teeth has been trimmed and polished and then bonded with each other with the help of acrylic resin. This is the post-rehabilitative view. This is the pre and post-rehabilitative view of the patient. So to conclude, as I told, we need a complete examination of the patient is most important in many cases because if we examine the patient thoroughly, we can identify even a minute abnormalities or any anatomical variations which is inside the patient mouth that we have to modify in the our complete denture fabrication techniques, which will helpful to gain the retention, stability as well as comfort for the patients. So to summarize, if patient is having a flabby tissues, we can go for window technique. If patient is having resolved ridges, we can go for all green or neutral zone recording. If a patient is having a shrunken cheeks, we can go for the complete denture with cheek plumbers. If a patient is having internal space of more internal space, then we can go for hollow denture to decrease the weight of the prosthesis. If patient is having a xerostomic, patient is xerostomic, then we can go for salivary reservoir. If patient is getting the denture fracture because of remaining natural teeth in the any arch, upper or lower arch, then the opposing arch can be rehabilitated with the help of metal reinforced denture. If some remaining teeth, which is predominantly sound, is present, we can go for overdenture. Along with that, we can modify the denture according to the problem in the patients, like gag reflex, we can remove the palate. If patients are in clitoral maxilla, we can remove the branch also and reference. For forensic identification, we can give a complete denture with labeling. Then the our digital denture, which is evolving a lot now. Even CAD CAM denture is also evolving a lot. Thank you.